Good day, everybody. My name is Raez. I'm the Chief Scientific Officer and Medical Director of Memorial Cancer Institute in Miami, Florida. We are going to talk today about two new agents for lung cancer. In a previous video, we talked about two agents that were approved in May and June. And now we're going to talk about a couple of agents that were approved in June and July. It has been an amazing journey for the lung cancer community because now we have 4 new drugs that are going to benefit and help our patients. So today we're going to briefly review Datopotamab Deruxtecan. We call them Dato-DXd. This is for EGFR positive, EGFR tumors, in lung cancer patients that have EGFR positive tumors, EGFR mutations. And then we're going to talk about zumbocertinib. This is for EGFR tumors, but the ones that have the exon 20. Remember, these exon 20s are less than 10% of the patients. It's very important because the classic therapies for EGFR, like osimertinib, don't work. So that's why it's important that we develop drugs also for these exon 20 insertions. Okay, so the first agent is, I said, Dato-DXd. These targets, the target for this is called TROP2. And this was approved in June 25 this year. What is TROP2? If you haven't heard of TROP2, it's a transmembrane glycoprotein that is highly expressed in lung cancer. You can see 65% of adenocarcinomas, 75% of squamous cell carcinomas, but it's not only unique for lung cancers. If you already heard about the drug, it's because most likely you have seen that the drug is being used already for the breast cancer community because it works for breast cancer. If you can see in the cartoon, there is a lot of transmembrane glycoproteins, and we have agents for that. For example, Claudin, there are drugs now for Claudin. We have drugs for NRG1, and we know that ERBT3 activation is very important, and we're developing drugs for that one. But anyway, we're going to basically now focusing in TROP2. Years ago, they discovered that the high expression of TROP2 is associated with bad prognosis. That's why it was necessary to develop a drug to target this genetic alteration to benefit our patients and to stop the lung cancer. This drug is not approved based on the biomarker. So in other words, we don't have to do, as you can see downstairs, there is a staining, immunohistochemistry staining of TROP2 glycoprotein. You can see TROP2 0, 1, or 2. The approval is not based on staining yet. Maybe come later, but now it's not based on this, yeah? So we don't have to do the staining. Don't worry for that. I know there is a lot of markers that we have to do. The story is a little bit long. Probably, maybe several people is familiar with this because we have been discussing TROP2 for the last 2 or 3 years. And the reason is because the first time, I guess, that the TROP2 came to the public arena strong is when they presented this phase 3, the TROPION-Lung1. Because the TROPION-Lung1 show, this was our patients that have metastatic lung cancer, second line. They've already been treated before, so they go for second line. And these patients have squamous and non-squamous histologies. And it was in the news, that you can see in the left, that these patients that were non-squamous cell carcinomas, Dato-DXd performed much better than docetaxel. There was a 37% improvement in progression-free survival with the Dato-DXd compared with docetaxel. And that was very appealing to us because docetaxel is the de facto second-line therapy. So now Dato-DXd was positioning as an option, and you can see the response rate even went from 12.8% with docetaxel to 31%. And the only thing that it was unexpected is in the right, that the squamous cell carcinoma tumors did not perform very well, and Taxotere was able to have better outcomes than the patients that got the Dato-DXd. So far, until this point, we knew that the Dato-DXd is better for non-squamous histologies, and the research continued. There was another study called TROPION-5 that included EGFR mutations. It was a single arm. But to make the story short, I want to present the data that was used to get the approval. So basically, they combined these two studies, the TROPION-1, because in the original one I just presented you, there were EGFR patients, and in this one, there were TROPION-5, there were more patients with EGFR mutations. So combining both of them, they created, as you can see here, a pool. What happened with these EGFR patients that were treated with TROP2? And you can see that there is a very impressive overall response rate of 42.7% in patients that have EGFR. And we're talking only overall response rate. If you look downstairs, stable diseases, you have another 41% of patients with stable disease that also benefit. So in other words, the number of patients treated with Dato-DXd that carry EGFR mutations is very small. Yeah? The duration of response was 7 months, the progression-free survival 5.8 months, and you can see in the right, the overall survival was 15.6 months. 15.6 months is a lot for patients that have failed already osimertinib therapy, or they are in second line. You know, you don't achieve 15.6 months if you give our standard of care docetaxel, because, you know, the drug is not as efficacious and it's toxic. And that's also another question. So if we are going to use this agent, what is the toxicity profile? If it's worth it or not? You can see in the right upper quadrant, we have toxicities like, you know, for oncologists, you see stomatitis, that makes you uncomfortable because this is something that we are not used to, but now, you know, we have to deal with that. But you see stomatitis is only 9% grade 3. Stomatitis grade 1, by definition, you don't feel it. You have it, but you don't feel it. So that's why a lot of this stomatitis, maybe if it's grade 1, it's not going to be bothering our patients. And there is a lot of measurements that we do. We can go from ice chips to steroid rinses and things like that to try to. We also use this pink solution. The patients call the pink solution. You know, that we call magic mix, that we mix Benadryl with Mylanta or Maalox and lidocaine, and then we make a solution for the patients to relieve and numb the pain. Anyway, but you can see most of these adverse events: alopecia, nausea, fatigue, decreased appetite, constipation, vomiting, rash and pruritus. Most of them are only grade 1 and 2. That's why there is no, so far, red flag. Maybe in the left, one red flag can be ocular events. You know, if you have a little bit of keratitis, it's another thing that scares everybody. But you see grade 3 is only 3%. In the study, the investigators require eye exams, but if you are asymptomatic, you know, I guess you don't need a baseline eye exam because we assume that you are fine. But if the patient has any visual disturbances, most likely probably is going to need new glasses. But I think it's important to recommend that if you are going to use this drug, you need to send somebody to ophthalmologist if you have any visual issue or visual problem. And, you know, remember, don't scare the patients. The chance to have a severe one is very low. And it's still, like any other ADCs, there is an important grade of ALD. So in summary, in previously treated patients with non-small cell lung cancer that they have a EGFR mutation, if we use 6 milligrams of Dato-DXd every 3 weeks, based on the TROPION-Lung5 and TROPION-Lung1 studies, we have this new approval with a response rate of 42%, and I already mentioned another 41% of stable diseases. That is meaningful for us, that outcome too. And the toxicity profile seems to be well tolerated.